All right, so after Dr. Schmidt's excellent lecture, we're going to go on to talk about a little bit more of other things that are in the pelvis. So point of care ultrasound beyond just the IUP. So I'm going to structure today's lecture by going from the inside to the outside. So we're going to talk about findings of the gestational sac, within the gestational sac, including normal and abnormal findings, and then move out to the uterus, talk about a couple of pathologic things that you may worry about, and then outside the uterus as well, including some things that you are already comfortable with a transabdominal probe, but sometimes look a little bit different on endocavitary. So first, talking about the inside of the gestational sac, we'll talk about measuring the heart rate, finding the gestational age, and then also a couple abnormalities that you may notice. So fetal heart rate can be helpful, especially in a patient who's coming in who's concerned about their first trimester pregnancy and bleeding. It can give you a good sense as to whether or not a pregnancy is likely to be successful, because if the heart rate is above 120 at 6 weeks or above 158 at 8 weeks, then that's a good prognostic sign for the pregnancy. If you look at this picture right here, what we're seeing is at the top, there's uterus, and here's a nice gestational sac. Here's a cute little yolk sac and a cute little fetal pole. And if you look at it really carefully, you can see the two black and white pixels that keep flipping on and off. So that is the heartbeat right there. The challenge with this is with your M mode button down here, getting this traced line on here and getting it right over this teeny tiny little pixels, hitting M mode again and getting a tracing that looks like this. You want to freeze it so you can take a look at it. And then the next step is the calipers. And this is always where it gets challenging in these very early pregnancies, because every time mom breathes, everything disappears. And then when mom breathes out, it all comes back again sometimes. So one quick little trick that I can show you is that if you look up here at this little thumbnail picture of the ultrasound, you can actually see where the fetus is. And it's right between 4 and 5 centimeters on the measurement. If you look down here on your M mode scale, between 4 and 5 centimeters, right here is this cute little tiny tracing where you can see those two little black pixels, black and white pixels fighting it out. So here's black, here's white, here's black again. You want to put your calipers at the beginning of some sort of repeating pattern. And then the magic happens when you remember that there's a button down here. This is the hard part, is this measures in distance usually on M mode. You have to tell the machine that you actually want it to measure time. So you hit this little heart rate button down here. It's actually not a button on the screen. This is just a thing that tells you to hit this button down here on the keyboard. And then it will turn these calipers into lines that will tell you the actual heart rate. So 143 is a very healthy heart rate for a 6-week pregnancy. So you can give mom that reassurance that so far things look good. Next step is looking at the gestational age. So gestational sac can be used to give you a sense as to how far you're in the pregnancy, but will not give you a good gestational age from like diagnosing or predicting when they're actually going to deliver. But it is helpful if you don't find anything in the uterus. So if you measure out a gestational sac and it shows that it's, it should be at 8 weeks of pregnancy, and when you scan through it, you don't see anything, that can sometimes be helpful in you trying to help mom sort out what the symptoms are that she's having and what her next steps are. Crown rump length is much more accurate, and it's what we're going to talk about doing next. This is actually can be really helpful because most women, as in 50% of them, don't actually remember when their last period was when they become pregnant. Or they have irregular periods, so it doesn't matter if they remember when their last period is. It was just, well, I don't know, but I'm pregnant now, so figure it out. And the earlier you do this in pregnancy, the more accurate this measurement is. I'll go back to this one really quickly. When the fetus is this small, even though we call it a crown rump length, it's a fetal pole length. You just measure how big the little line is, and that's as big as it is. Once you get to this point where you can actually see limbs, then it actually matters that you're actually getting a crown to rump length. So here's the baby's head. You want to get this baby in this long axis view. Spine right here, you can see, like, if you see a very subtle white, black, white, that's spine back there. You want to measure from the top all the way down to the butt. Don't include any limbs. If you want, in order to get this cool little calculation thing up, so you don't actually have to guess or look this up, you hit the calcs button that's down here on the edges, and then use the select button to pick which one of these many, many estimations of gestational age you can choose from. And then use your calipers to measure it out, and it will sort it out for you and spit out a number for you. Once kids get larger, it's harder to see them because they're the entire screen and all you have is fetal parts coming at you. Sometimes you can identify one of those fetal parts as a femur, and I've seen a lot of emergency physicians use this. If you can get the femur lined up with the transducer face, so it's a little straight line across the screen, it's going to be pretty accurate. You want to just measure the length of that line of that diaphysis. And then the other one that I'll most commonly see, because we want to know if a patient comes in late pregnancy, we want to know where that head is anyways. So it's not unusual for people to do biparietal diameter. Because we are trying to get right up to that head to find out if it's pelvis, if it's in the pelvis, or if it's not. So this is a sonosite educational video, but it's really good. So there basically is you find the baby's head, and you want to rotate the probe onto short axis of the head. What you want to identify is there's this hyperechoic bulks through the middle of the skull, and then these little two black legs that look like a little black butterfly, the thalami. And you want to make sure that you measure right across this area if you can. If you can't, then you're just getting a slightly less accurate measurement, but it still is going to be a measurement. You want to measure the widest point of the skull, basically from ear to ear, okay? You measure outside of one side of the skull to the inside of the other side of the skull. All right, other things you may find in the gestational sac is this. So you have this is uterus right here. This is up in the fundus. Here's the gestational sac, kind of all around this area, but specifically here is where the baby is. There's going to be a little yolk sac here and a little fetal pole. But here next to it, there's sludge. Is this like kind of hypoechoic, sort of heterogeneous material. This is called a subchorionic hemorrhage. It's just a little bit of bleeding where the chorion sort of separated, has a little bit of bleeding next to it. If these are large, they can be a sign of a impending miscarriage. This particular one, if you look at this little, if you can catch a spot where this little fetal pole is, you'll actually see that its little heart rate is beating pretty good. So this fetus doesn't care at all about this subchorionic hemorrhage. You don't have to worry about these to the point where there's nothing you can do about them. Generally, it's not even clear in the literature whether or not they're clearly prognostic for miscarriages or not. And so basically, they just suck if the patient knows about them and can worry about them. So in general, I don't usually tell patients about them. It's just something to be helpful to know, oh, what's that big blob? That big blob is a subchorionic hemorrhage. All right, so two quick cases here. First one, my stomach hurts. I don't think I guess I could be. But yeah, no, I don't know when my period was. Why would I know? So you're going to help her out. Her period was approximately 6.5 weeks ago. Another case, so I had a patient who came in somewhere around 26 weeks, and they're like, I don't know, I was fine, and then all of a sudden my stomach just blew up, and her friend is sort of like looking at her in the corner of the room, smirking at her. And then Chris Stammer, for those of you who know him, had a similar patient show up at TAC who didn't know she was pregnant, but showed up with pain every 5 minutes. So you pull out your ultrasound machine just to find out what's really going on. You measure your biparietal diameter, and you find out that this person is about 36 weeks and going to marry her. All right, last case, early pregnancy bleeding. So patient presents. She has not had an ultrasound yet. She just found out she was pregnant a little bit ago. And she has this is a transabdominal ultrasound, but you see a big uterus. You see, how many are here? 2. There's lots of circles here. So these two are gestational sacs with little fetal poles in them. These 2 are complex cysts on an ovary. And this last one is this kind of slushy stuff. What's this? It's a subchorionic hemorrhage. Do we care? No. All right, we'll congratulate her and tell her we hope things go well. All right, placenta. So we don't usually talk much about placentas. They just sort of hang out on the sides of our point-of-care ultrasound to the point that I actually had trouble finding a clip of one because we really don't pay very much attention to them. But placentas are basically hyperechoic, kind of regular echo texture with a few areas of anechoicness because they've got vascular lakes, little venous lakes, and some other connections that can show up on them. For the most part, they should be less than 4 to 5 centimeters thick. So if you see a placenta that looks like this, where there's a baby head, and then there's a blob, and then there's another blob here before we get to the uterus that's bigger than the baby's head, that can be what's showing right here, which is a placental abruption. So if you remember from the pregnancy cases that you've seen in the past, placentas can start to separate a little early and you have bleeding. It can sometimes be hidden, which in this particular case here and here, it would probably show up as vaginal bleeding. But up here it gets hidden. And this is 85% of these are retroplacental. So they're showing up behind the placenta and you may not actually have any bleeding, but the patient may notice changes in how much the baby is moving. MRI is the test of choice, which tells you how emergent this is that this is really something like something's not quite going on the way that it's supposed to, what's going on. This is usually not an emergent finding, but it may be helpful for you to notice what it is if you have a clinical picture that's pushing you this way. I'm not recommending that you make this diagnosis by point of care ultrasound, which is pretty much always the answer if MRI is the test of choice. But if you see these blobs in the uterus while you're looking at something, it might be useful for you when you put it together with the clinical picture. All right, so moving on to within the actual uterus outside of the gestational sac, we'll talk about eccentric pregnancies, which Jessica already covered beautifully, so I'm going to go over very quickly, and then uterine rupture. So these are another 2 cases of interstitial pregnancy. She talked about that it should be 8 millimeters between the gestational sac and the myometrial, the edge of the uterus. You want to measure it in both planes to make sure that you're actually getting the thinnest area. Here is, this is from the case from Teaming This Room, which was interstitial. You can see this uterus is, the endometrial cavity is way down here, and this pregnancy settled in the endometrium, but kind of just moved way too close to the edge of the uterine wall to be safe for this patient as it moves forwards and gets bigger. Here's another case that was at Beloit, which was correctly diagnosed as a cornuate pregnancy, although I love that they wrote corneal pregnancy. I would suspect that has a different complication pattern than this does. But if you look at this one right here, 0.6 centimeters between the edge of the gestational sac and the myometrium. And so this is going to be dangerous for this patient. I don't recommend either that you make this diagnosis, but I recommend that you notice it. This is in the list of things that you need to notice, and then send them on to radiology to have them take another look at. All right, uterine rupture is bad. This is the painful pregnancy emergency versus the vaginal bleeding for placental abruption is usually painless. It's also not a point of care diagnosis, but it's useful to know what you might see. So I have 2 cases here about uterine rupture. One of them is, I just have freeze frames for it because it was a case report from a relatively low resource country, but they had person coming in with abdominal pain, so they started with a pregnancy evaluation and followed with a fast exam. Pregnancy evaluation was not very positive as there's nothing in this uterus. You can see the endometrial stripe right here, and there's free fluid behind it and above it. And then once they looked up in the right upper quadrant to see if there was a free fluid, they did find free fluid, but they just chose to submit to the journal instead a picture of the gallbladder with a fetal head next to it. So that is a problem. Once again, I don't expect you to figure out if the uterus is ruptured if the baby is still in it, but know that sometimes this is what happens instead. All right, I guess the next one's case. All right, so cases, early pregnancy, 7 weeks maybe by last menstrual period. She's super sick. She hates pregnancy already. She says, this is awful and not like my previous pregnancies. And it's just uncomfortable. I just don't feel very good. It hurts when I move. And she has this in her uterus. This is transabdominal. They tried transvaginal, but the uterus was too big, so they stopped and they tried transabdominal instead. What do you guys think this is? Molar pregnancy, exactly. So hyperechoic material with these kind of fluid-filled anechoic structures that look sort of like we're ultrasonic grapes in a snowstorm or something. Here's another case. This is 3rd trimester bleeding and abdominal pain. It was blunt abdominal trauma from an MVC where she hit her abdomen. Fairly decent crash. She's at 29 weeks. She shows up a little bit tacky, which she's pregnant, so that's not too surprising, but also in a lot of pain. So they did the fast right away. What do you guys see in this right upper quadrant and this left upper quadrant? Free fluid. And this is what's going on down here in the pelvis. So here's baby. She knew she was at 29 weeks. What do you guys think about that? It says it right there, so. Baby is moving slow. That heart rate is not what it's supposed to be doing. So this baby is very, very distressed. So they sent her directly to the OR for an emergency C-section. And the baby came out of the abdomen, basically. As soon as they incised the abdomen, the baby was an intraperitoneal object. So was removed quickly. And mom did okay. They actually don't mention the case series about the baby, so I don't know how the baby did. All right. Moving on to outside the uterus. So we'll talk about ovaries, free fluid, and a couple other things. Once again, things that the other and the free fluid you guys know well from a transabdominal ultrasound, but it's a little bit different when you see it on endocavitary. So I have a few examples for you. So first we'll talk about finding the ovaries. So when you're looking for the ovaries, I already talked about this in our room at least, is that you want to start when you've already found the uterus, you don't want to lose the uterus. So you want to look at where your hand is and find out where you're holding the probe. If the patient's uterus happens to be pointed a little bit to their left shoulder and the probe is kind of down a little bit, you want to make sure that you're holding you can get back to that spot. You want to sweep to the annexa. You'll look for the ovaries between the uterus and the iliacs. And then the last view is going to be your coronal view. All right, so step by step. First, your starting position. Patients have a tendency to not have their uteruses midline, and so find out like, oh, I'm pointing a little bit to 10 o'clock and my hand's lifted a little bit. That's where the uterus is. That way, when you slide back and forth, you're like, I have no idea where the uterus is. You probably pushed the probe in too far, so you can just put your hand back to where it was, and then there's uterus on the screen, okay? So that's first, and then you want to sweep to the annexa. So this is a little fast, but they're sweeping from side to side, and they find this on one side, and there's an identical looking one on the other. So here's a ovary, hypoechoic, black circles, look like little follicles, or a chocolate chip cookie, sort of. Here's the other ovary on this side, and they're swinging back and forth. So there's one ovary down posterior, and there's one over here. Okay. This is my favorite spot to find them, is in long axis. If you get as far as the iliacs, in our model we couldn't see iliacs very well. I don't know what has happened in the other room. But if you get to these like little dark double lines here, the little like divers flag look, the ovaries are always going to be medial to that. So they'll always be above it and medial, regardless of which side it's on. So this is a little complex ovarian cyst, a little bit of free fluid around it. This up here is bladder. You can tell by the thickish wall that's kind of sitting around it. It's well contained. All right, so this is, if you get to this point down here, iliacs, you want to just turn around. If you can't find it with that, then go ahead and switch to coronal view. The ovaries have a tendency to sit right next to the uterus, so if you're just losing them in the kind of the mess of bowel as you go from side to side in sagittal view, sometimes it's just a little bit easier to pick them out when you're in this short axis view, because there's one ovary over here, right there, and then there's the other ovary is down here. Dr. Damewood likes to teach that this is Yoda. So here's the head. Here's one Yoda ear. Here's the other Yoda ear. This is a sad-eared Yoda on this side. And once again, just be systematic. You want to go slowly. You want to look at from side to side. This is here they find it. They push in a little bit further to get a better view of it. This is ovary right here. These other circles that are out here is vascular plexus, which is always a little bit confusing, is that there's other circles and lines out there too. Once you find it, then we want to identify if there's anything wrong that's going to cause problems. Whoops. So this is a simple cyst above a uterus. So big simple cyst, bladder. We'll talk about the differences between them. First, we'll look at the ovaries in general. So normal ovary with little follicles, lots of follicles on this particular ovary. Simple cyst versus a complex cyst. And here's a mass, and radiology will not differentiate between masses and complex cysts on ultrasound. It requires a different modality. And then here's a picture of a hydrosalpinx. So this is an inflamed fallopian tube that can't drain the fluid, so it ends up looking like a little black corkscrew. Okay. So simple cysts have to fit all of these rules, otherwise it's not simple. It has to be thin-walled, anechoic, posterior acoustic enhancement. Remember, that's when it's brighter behind it than it is in the surrounding tissue. And no color flow if you were to put color Doppler on it. Anything that breaks any of those rules is going to be a complex cyst. So here's one that has thick walls. Here's one that has contents. So both of those are complex cysts. You can see them on transvaginal. You can see them on transabdominal. This is a transabdominal ultrasound of a uterus with a complex thick-walled cyst. So even though there's no echoes in it, it is considered complex. Doesn't necessarily mean it's pathologic. It just means it's not simple. So if you find a big cyst, why do we care? And the reason is because sometimes those big cysts make those ovaries unwieldy, and they have a tendency to flip over and get stuck, and then you get ovarian torsion. So signs of ovarian torsion are going to be a big, huge ovary, because usually what happens is once it twists, the venous system is cut off, but the arterial system is higher pressure, and so it continues to perfuse that ovary. And so you get more and more blood pushed into that ovary, but there's nowhere for it to go. So the ovary gets bigger. The ovary gets some free fluid around it because it starts to weep and has a little bit of edema. And also, interestingly, you get with these little peripherally displaced follicles. So all the follicles that were like all mixed up in that ovary are all pushed over to one side. The other thing that can happen is that ovary can be midline. So if you're ultrasounding a person who has acute onset of abdominal pain, nausea and vomiting, that's kind of high concern for torsion. If you see that they have a big ovary, then the next step is to, and this is a big complex like hemorrhagic cyst on an ovary, the next step is to get them definitive testing or treatment, depending on your clinical concern for ovarian torsion. That's often, for us here, it's really easy. We just ask radiology to come over from like one floor down and come over and ultrasound the patient. But in some places it requires calling them in or actually transferring that patient. Last thing is I don't expect you guys to do Doppler on it. We talked about this in one of the rooms because this patient should have Doppler flow if this ovary is still viable. They should still have arterial flow. And I don't expect anybody to differentiate the difference between venous and arterial flow. We know that even radiology can sometimes have a false negative for ovarian torsion. All right, free fluid. So once again, Dr. Schmidt talked a little bit about free fluid in the posterior fornix. So this is a picture of a little bit of physiologic free fluid. So it's not unusual for women to have a little bit of free fluid in the abdomen. We don't usually see it on transabdominal views, although sometimes I'll see it in patients who have pretty big bladders. They'll just have this kind of idiopathic free fluid that's just sitting there and can be confusing from a trauma standpoint. This is not so physiologic. So here is uterus right here. This uterus happens to be retroflex, so it looks a little bit different. But around it, you'll see there's a big pocket of free fluid behind, posterior to it. And then on the anterior side of this uterus, there's a bunch of vascular plexus here. But up here at the very end of this, we see there's a pocket of free fluid, and it kind of loops around the bowel. Sometimes the bowel being really obvious is how you can pick up on these free fluids instead of like fluid that's contained in the bladder, because you get those sharp corners around the bowel. As I promised this morning, Dr. Schmidt already presented this picture right here. So this is a patient who has a lot of free fluid in her abdomen, but it's not easy for us to tell what it is, because what is it? So this is, as she said, this is the drumstick right here, okay? This is bladder up here. And then what is all of this? Clotted blood, yes. This is a ruptured ectopic, and all of this is blood clot. We'll see this in traumas too. We'll see up by the spleen, we'll see people who look like they have two spleens because they got a blood clot up here and then they have a spleen below it. And so you'll have very similar look where you just have this like big blob of like kind of hypoechoic stuff instead of actually free fluid. There's little pockets of free fluid. If you look around, there's like a little tiny bit back here. There's a little probably tiny bit in different areas, but most of this is blood. So it can be a little bit of a false negative. All right, couple cases for outside the uterus in the pelvis. This is a patient who, as Dr. Kitab said, came to TAC, because that's always where you go when you're having troubles with gynecologic and OB problems. She's doing IVF, and her OB is out of town this week. So even though OBs are really, really cautious with these people and take very, very good care of them, her OB was out of town, and she was having trouble getting hold of the person who was supposed to be covering. She says, first I was really bloated. I've gained 10 pounds in the last week. Now I'm short of breath, and I'm dizzy, and my stomach hurts so much. This is her ultrasound. So she has a ton of this, ascites. This is her uterus right here, kind of swimming in amongst these big, huge circles or cysts. So she had, does anybody know what this is? Ovarian hyperstimulation syndrome, exactly. Which I have to admit, I never really had a great handle on until I saw this patient. I'm like, aha, I now totally understand what this is. She was, like, even her right upper quadrant was just the gallbladder, like, floating in fluid. She had so much retained fluid. We did eventually get a hold of her, the OB who was covering, and he had me send her right on over so he could evaluate her for admission. All right, so another patient presenting with right lower quadrant pain. Her last menstrual period was 3 weeks ago. This is the right adnexa over here. Here's uterus right here, endometrial stripe. What do you guys think? Just free fluid. What else? Yeah, she has a gestational sac that is not in the gestational sac area. So I forgot to say it earlier when we were talking about the eccentric pregnancy. I'm trying to find the little yolk sac in here because there is a yolk sac in here, which is sort of scarier than anything else. is one thing that I learned as a resident is to not only check to make sure that the gestational sac is inside the uterus, but to do double check and make sure that there's actually uterus all the way around that gestational sac. Because these ectopic pregnancies do have a tendency to show up right next to the uterus because they almost got there, but they got stuck in the fallopian tube. And so it's really easy to transition. You guys have already done a couple of these ultrasounds. Like, it's really easy to not lose track of what's uterus and what's the tissue right next to it. And so it's really easy to sort of like slid into this ectopic pregnancy and not notice that you have slid out of the uterus. So just do, when you find it, do a double take and be like, okay, I know where I am, what's around me as well, and make sure that that myometrium is nice and thick around it, and you're actually in the uterus instead of over here is the uterus going, hello. This is case 2 continued with the requisite, this is actually a patient who had a ruptured ectopic. I told the OB about this in Beloit, and he showed up right away and took the patient away. It was excellent, excellent care. This is somebody else's case, but I actually had this case at Beloit where I was doing an endovaginal exam on somebody who had right lower quadrant pain, and she had a non-compressible little circle of fluid that looked just like that last ectopic we just saw, and I'm like, are you sure you're not pregnant? And then figured out as we moved along that that long axis line that came from it was actually an appendix. She actually had appendicitis that I was finding on her endocavitary ultrasound. So you might see the appendix butt up against it. It's not unusual. This person has a concerning amount of free fluid sitting around here too, which might indicate that this appendix is fairly far along. This particular one also has an appendicolith. All right, I think this is Dr. Gauger's case. I don't remember if there was a resident who did it as well, but he's the one who recorded the images and submitted them to us, which is excellent. What do you guys see here? So this is transabdominal. Here's bladder right here. Here's uterus. This patient has had abdominal pain off and on actually for weeks, but it started to get a lot worse in the last week or so, in the last 2 days. What do you guys think? What do you see? It is an IUD. If you were an IUD, would you prefer to be in the top picture or in the bottom picture? I think the patient would agree with you. So this top one is a perforated IUD. It's actually not unusual for these to start to move out of where they belong. Typically, we start searching for them with a KUB to even see, like, is it actually in the pelvis? Is it in weird spots? Sometimes it's hard to see them on ultrasounds, and so they could be in the uterus, but you just can't see them very well. But if you do happen to run across an IUD that's deciding to leave the uterus, this is one example of what it might look like. All right, so we talked about what happens inside the uterus. So we learned how to measure heart rates, gestational age, and also look for hemorrhage and abnormalities of the placenta. Talked about eccentric pregnancy again and uterine rupture, and then last talked about ovaries free fluid and everything else. So thank you very much for you guys' attention.